Jordan. So I'm Malcolm King. I'm a member of the Mississaugas of New Credit First Nation. And in effect, I guess our nation is co-host of this conference along with Canada. So on behalf of Chief Stacey LaForme, who is not able to be here, I'd like to welcome all of you to this venue, to Toronto, on behalf of our nation. We recognize the many nations who walked these lands in the past, and those who walked them together today. And we welcome you to the treaty lands of the Mississaugas of the Anishinaabe. Now, I will give you a little bit of a background. This is a drawing from a painting of Chief George King. He was my great-great-grandfather. He was born over just in almost eyesight of here on Toronto Island in 1815 when it was still unceded territory. He grew up along the banks of the Credit River in what's now the city of Mississauga. That was our village at the time until 1847. In 1847, he was then in his 30s. He was part of a group of 200 or 300 of our band members who packed up and moved to get away from the growing city of Toronto. Probably a good idea. In any case, they went out to the area south of Hamilton to join in a little corner of the large reserve that's occupied by the Six Nations of the Grand, the Haudenosaunee people. And that's where we lived to this day from 1847 to the present. George King was the last of the hereditary chiefs, the traditional chiefs, in 1870, and then he became the first elected chief with the new style election. The next picture I'm going to show you is a composite, and I'm not going to spend a lot of time with it, but now you see Chief George colorized, very colorful, but that was added his modern way. In the middle are my parents, and the reason for showing you these kinds of things is that Indigenous peoples, most places, perhaps throughout the world, are relational people. We think about our relations, and we need to situate ourselves in the context of who we are as Lloyd and Margaret King. Lloyd King lived all his life on our reserve. He was born there. And my mother, Margaret, was Swiss, and she came there, got married, and was the result. That's little me down there at the bottom, Bachelor of Science grad from McMaster. That is myself and my wife, Alexander, who we were here, thanks, when we got married in New Zealand. The other things I just want to finish with a couple of slides of our modern day reserve, the Mississaugas of New Credit, past Hamilton. Our people today are striving to regain wellness through culture, language, and health-giving activities. So we have things such as our powwow, our children in school are learning to drum and dance and learning the Anishinaabe language. That's my nephew Carl there with a group of children. And this is all in the spirit of Canada's reconciliation with Indigenous peoples, with First Nations, Inuit, and Métis. It's the spirit that we need to have the resetting of that relationship between Indigenous peoples and Canada's settler peoples that will lead us all to better health and wellness. So with that, I welcome you, Chief McQuaid.
And it's now my privilege to introduce to you Alexandra King, who is a physician, really a leader in viral hepatitis care in Canada. She also comes from the Nipissing First Nation here in Ontario, but now is in Saskatchewan, and will tell us about effective viral hepatitis control strategies in Canadian Indigenous populations.
So hello, everybody. Thank you, Jordan, for the lovely introduction, and I'd like to thank the meeting organizers for having me present. We were supposed to do disclosure slides, and essentially I have received a grant from Gilead as well as some speaker fees from various pharmaceutical companies. I have no commercial support to be declaring. And there was a slide about mitigating potential bias. And I would have to say that what I have done with my speaker fees and honoraria is I've used them to allow me to travel to more rural and remote areas, and in fact, different talks and so on in those areas. But additionally, we're using them to pay for cultural items, ceremonies, as well as our elders honoraria and travel. So I wanted to start first by just talking a little bit about the Indigenous people in Canada. And this is actually a slide that was courtesy of Dr. Brenda Elias at the University of Manitoba. And the reason why I want to put it up is to start off with the fact that Canada is a negotiated country. It is a series of treaties that have brought us together. There was never any definitive war or battle where Indigenous people said, you're right, here's the land, we'll somehow move around or something like that. But rather, there were a series of treaties. Mostly the settlers came from the east and continued west across the country, also north. And then there were a few treaties that were on the west coast, mostly because of the Spanish. And so some of these treaties go back over 400 years. We have some modern day treaties. And so I think it's really important to recognize that settlers were welcomed. We recognized that we would be living together and trying to figure out a way that we could live together well. In terms of who the Indigenous people of Canada are, there are three different distinct groups that are recognized: First Nations, Métis, and Inuit. First Nations make up the large majority of the Indigenous population. There are over 630 different First Nations in Canada, and they really are quite diverse. Over 50 different languages. There are a variety of legal aspects to being First Nation, and these are mostly imposed by the federal government. So we have status and non-status, and then you also have treaty and non-treaty. The Métis are the second largest group, and they are basically a blend of First Nations and European ancestors. And then finally, the Inuit that tend to live up in the north as well as the east of Canada. On the right side of the screen, you're seeing an age distribution graph with Indigenous people being the light blue and the rest of Canada in the dark blue. And what's significant is that we are a very young population, and you will note that there are fewer of us in the older age groups, whereas in the non-Indigenous population, there are more people. The bottom two circles, the one on the left is showing the split between urban and rural. And so the light blue is your rural population. And so you can see that many or more than half of Indigenous people are now living in urban centers of various sizes. The one on the far right is showing the split between on reserve and off reserve. And so again, what I think is significant is that more of us are no longer living on reserve or in community. This is from the 2016 census. So we're looking at the number of people who self-declare as being Indigenous. And it's basically 4.9% of the population. Of interest is that as you go from east to west, generally speaking, we start with lower numbers and lower percentage, and then it increases. Sorry, just to back up a little bit, the red in the red triangles are indicating the percentage of the Indigenous population. The black text is showing the absolute numbers. So out in Atlantic Canada, you might have 2 to 4%, let's say. As you go through Ontario, again, it's still fairly low, but as we hit the prairies, Manitoba's 18%, Saskatchewan 16%, and then back down to about 6% in BC. When you go further north, the percentages of the population increase significantly. But it should be noted that as an example, in northern Saskatchewan, and by northern, I'm talking about north of, let's say, Saskatoon or Prince Albert, the percentage of the population that is Indigenous is 85%. You're seeing the same thing in Manitoba. So you're looking at very significant percentages of the population, even within central Canada. In terms of hepatitis C, these stats are coming from Saskatchewan, and I would like to thank Dr. Ibrahim Khan, who is from the First Nations and Inuit Health Branch, for lending me this slide. And basically what we're looking at is very high rates of hepatitis C, 129 cases diagnosed in First Nations communities, or what some people will call reserves. The rate is 171.6 cases per 100,000. You're looking at a fairly young group of people, aged 30 to 39, mostly men, 65%. And in comparison, when you look at the Saskatchewan provincial diagnosis rate, it's about a third compared to the Indigenous one. There's also quite a north-south gradient, but some of this may be related more to testing than anything else. This is another slide that again is showing hepatitis C. The black line along the top is showing incidence rates in First Nations communities. The red line is showing your Indigenous or First Nations rates, generally speaking, for the province, and then the bottom line is showing them in Canada. And so I think what's significant is obviously the rates are much higher in Saskatchewan, or sorry, amongst Indigenous people. This isn't Saskatchewan, but then also on reserve, you're seeing much higher. It is Saskatchewan, sorry, this is Saskatchewan. Just a bit nervous. So now then, this slide here is courtesy of Jason Greberly of the Kirby Institute. And I thought it was a really effective way to be looking at hepatitis C care. And you know, basically we have a long-standing tradition of a tertiary care model, and that was of necessity because of the treatment agents. And so we were trying to figure out how to get people into these big centers and so on in tertiary care facilities. We now, with the new drugs, have the option of delivering much more innovative models of care. And so the question really is, how do we get treatment out to where people are? And, you know, it could be in prisons. We could be talking about treatment clinics. And additionally, you know, primary care and so on. So really it is much more capable or much more amenable to us being very innovative. And I think that is particularly the case with Indigenous people. Our history is such that medicine and hospitals were used as tools of colonization, and so we don't tend to want to go there. And I think that if we're going to be getting to elimination or even micro-elimination within certain populations, we really are going to have to get out into where people are at. In terms of Indigenous viral control amongst Indigenous people, I think there are a couple of critical aspects. And the first one I'm going to talk about is self-determination. I think another component of this is determinants of health, intersectionality, and holistic. And I'm deliberately using a W in holistic because we're referencing the whole person rather than holistic medicine. So in 2006, more than 20 years ago, the Royal Commission on Aboriginal People published their report. And they talk about how Aboriginal people do not want to pay their handouts. They want recognition that these problems are largely the result of the loss of their lands and territories, destruction of economies, social institutions, and denial of their nationhood. They seek a range of remedies for these injustices, but most of all, they seek control of their lives. So this came out over 20 years ago. More recently, we've had the Truth and Reconciliation Commission table their calls to action, and they're saying the same thing, self-determination. So for us, I think one of the ways that we see self-determination happening is through such things as two-eyed seeing. And so this is a concept that was put forward by Mi'kmaq elder Albert Marshall. And he's talking about how it is important for us to take and look through one eye with the best of Western ways of knowing and through the other eye with the best of Indigenous ways of knowing. And it's when we're using these eyes together that you're really potentiating incredible healing. And so in the case of hepatitis C, let's say, where we have these wonderful new treatment agents, then we absolutely need the very best in Western medicine. But it is necessary, not sufficient. And so therefore, for many Indigenous people, we're wanting to bring in concepts of culture, land-based healing, other aspects of spirituality. So that way we can take and really be healing holistically. Another aspect that I think is going to be really important when we're talking about self-determination is this notion of trauma-informed care. And so this diagram is basically showing on the right the traditional Western or mainstream healthcare system. And you're seeing some concepts that one often runs into. So notions of health, it's very medicalized, it's pathology oriented. And in order to make this really work for Indigenous people, as well as other key populations or priority populations, I'm not sure what the particular term is right now, but we're bringing in concepts of cultural safety and competence. On the far left, what we have are Indigenous healing concepts. And so, you know, instead of health, we're looking at wellness. The spiritual aspects of a person are really quite critical. We use more of a strengths-based and holistic model. And when it's indicating self, we're really talking about self as in a relational concept. So it's not as a person, but rather how they relate in a variety of different contexts. And so overlaying the two then is this notion of trauma-informed care. And this is trauma-informed care from an Indigenous perspective. And so this is one of the things that would allow the Western healthcare system to be accessible or more accessible to Indigenous people. I had mentioned about determinants of health, and I think that this is going to be a really critical aspect when we're looking at hepatitis C treatment. And so we have the conventional determinants of health. These are things that are recognized in the Ottawa Charter or WHO and really apply to everybody. So income, social status, poverty, education, employment. Differentials are also really critical. If you're living in an environment where you're poor but everybody else is poor, it may not be as significant as if you happen to be poor in quite a stratified society. Social networks and genetics all factor into what is considered conventional determinants of health. Indigenous people also have some other determinants of health which come into play. And so Indigenous specific are colonization and colonialism, connectivity to land and country. That notion of self-determination is coming up again. And then you're also seeing that there's other things that will have Indigenous specific impact. And so this is from the Truth and Reconciliation Commission, their calls to action. And, you know, they're saying that they call upon federal, provincial, territorial, and Aboriginal governments to acknowledge that the current state of Aboriginal health in Canada is a direct result of the previous Canadian government policies. And so this is again linking ill health that we are experiencing right now, as well as a variety of social issues and so on, to in fact government policies. And that would be through colonization and colonialism. I mentioned intersectionality, and I've used a variety of different diagrams to try and explain it, and so I thought I would use this one this time. So a lot of times when we see people, we're either seeing, you know, this lovely flourishing tree, or we're seeing a more sickly tree, and a lot of times we're focusing on a particular leaf or something, so diabetes or hepatitis C or something like that, and we're trying to fix just a particular thing. And what I think is really important to recognize is that, in fact, all of these things are interconnected for people, and that you have to be treating them as the whole. And so therefore, it is not just a particular infection or a particular disease. It's not under housing. You have to look at the whole picture and have to be working with it in quite a holistic manner. The other thing that is interesting about trees is that when you think about them, their root bundle is often as large as what we're seeing above the ground. So there is so much there that is hidden, and it's in the history of the person, their family, and so on. And so therefore, again, when we're talking about intersectionality, there often is so much more there than what we may be appreciating. And I think it all needs to be considered. Sorry. And so as an example of intersectionality, I want to talk quickly about Indigenous identity and gender. So on the top left-hand corner, you have statistics. These happen to be HIV stats from Saskatchewan. And what is circled in green are the percentage of people who are identifying as Indigenous. And going back for the entire decade or so of that graph, you'll see that Indigenous people make up between 70 to 85% of HIV cases in Saskatchewan. We are 16% of the population. Additionally, as I'm sure most people in Canada are aware, we've been having an opioid crisis out in British Columbia. And there was news that was published that First Nations people in BC are 5 times more likely to experience an overdose and 3 times more likely to die from one. What's also, so that's where you're seeing the Indigenous people then being impacted. But also what's significant is that the fatalities are almost evenly split between First Nations men and women. In the non-Indigenous population, you're looking at this being significantly weighted towards men who overdose. Same thing going on in the prison system. So between 2007 and 2016, the overall prison population increased by less than 5%, but the Indigenous population in prisons increased by over 39%. And rather shockingly, 37.6% of women who are incarcerated self-identify as Indigenous. So you're looking then at that combination of Indigenous identity and gender. The last thing that I had mentioned was for any sort of effective control strategies for viral hepatitis, we need holistic concepts of wellness. This is something from the BC First Nations Health Authority, and it's one conceptualization of wellness, but I think that it really helps to show some of the complexity of how Indigenous people understand health and wellness. And so, you know, you're looking at the individual, the family, the nation levels. You're seeing the social, emotional, cultural, and environmental impacts. Within the individual, you have the physical, the spiritual, the mental and emotional, and so on. And so it's really showing how everything is very interconnected. This is how we understand our health and how we are seeking care. And so how this is conceptualized then within the world of hepatitis C, let's say, is that from an Indigenous perspective, mainstream hepatitis C care is just one aspect of what people might be, in fact, accessing for their overall health and wellness. And so we're trying to make that more accessible to Indigenous people, but I think also recognizing that there is this whole other wellness system at play. And that is the end of my presentation. I guess we're taking questions afterward?
Well, we're going to have a panel.
Right. Perfect.
Great.
I have the pleasure of introducing. Is it on? Oh, good. I have the pleasure of introducing the next speaker whom I just met. It's Merv Thomas, and he is a First Nations individual from Pelican Lake, Saskatchewan, and he's the director of the National Program and Communications for Canadian Aboriginal AIDS Network, and he's been responsible for overseeing the national programs and the communications. And he currently resides in the territory of the Coast Salish people in Vancouver, BC, near where I live in Alaska.
Thank you. So if I just want to first off acknowledge the traditional territory of Mississauga's New Credit, and I want to thank them for allowing us to be on their territory to have these meetings. And I just want to say thank you to Dr. Alexandra King and Malcolm. It's an honor to be here amongst illustrious company. So I just want to be first off acknowledge that. I've had 3 hours sleep last night, and I've been traveling all day with a little 5-year-old. So please bear with me if I fall over or something. As mentioned, I'm Neo. I'm Cree from Pelican Lake First Nation. I have 1 son and 1 grandson. I'm raising him and totally devoted to this kid. I was practicing my speech yesterday, and then I was saying, I said, maybe I'll just spend the whole time talking about my grandson. I don't know I don't know how many You really love your children, but you really love your grandchildren. So I'm the director of national programs, and I'm also the director of the Promising Practices films. And just a brief overview of the presentation. I'll talk a bit about CAN. We'll talk a bit about what community readiness model is, and then talk about the Promising Practices in Temiskaming First Nation and how they addressed hepatitis C using the community readiness model. CAN was incorporated in 1997, so we celebrated our 20 years last year. And in 2013, we began to expand our mandate to include hepatitis C, STBBIs, TB, mental health, aging, and correlated morbidity issues. We look at social determinants of health framework through advocacy, and we provide accurate and up-to-date information on these issues in a culturally relevant manner for Indigenous people wherever they reside. So for us, we don't see on and off reserve or the borders, and it's sometimes very challenging to work within the environment where you have PHAC is off reserve and FNIB is on reserve. So, but we try to do our work without recognizing those jurisdictions. Some of the programs that we currently have, we have a leadership project for both women and youth. There's an International Indigenous Working Group on HIV and AIDS. This is composed of about 11 countries currently. Currently, our coordinator of that program sits at as one of the UN reps at the United Nations AIDS. We have a project called Assessing Community Readiness in Indigenous Communities. I'll talk a bit about that more, and also the Promising Practices project. This year, the other thing that we've started to work on is the prevention education. We've done this work, as I mentioned, over the years, and all the work that we've been doing is from a holistic lens, which means that we work with the whole person rather than just pieces of looking at specific issues. We have Renee Mashing, my counterpart in Halifax, and she oversees the research programs. And I think currently we have about 12 research projects. And yeah, so they're quite busy. So in 2015, we received a small grant to look at, originally it was going to be 2 films. And one was about promising practices in Saskatchewan, which focused on HIV. HIV in Saskatchewan is amongst Indigenous communities is very high. And in some First Nations, like you're looking at numbers between about 63 people out of 1,000 are living with HIV. And that's just a couple reserves from my reserve. And so that community did a lot of work. And that film highlights the work that they did. But one of the things as well is that we're noticing that there's a lot of communities that are just in total denial. And I'll use my reserve as an example. I talked to our director of health and I said, what are we doing about HIV prevention or Hep C prevention? And she says, oh no, it's not here. So I was at home for a funeral and I found out my cousin was living with HIV. So they're total denial in our reserve. So we have, the second film we did was Temiskaming First Nation. This is the one I'll talk about a little bit later. And the third one was around harm reduction in Eskasoni. 2 of these films have won Impact Doc Awards. So what exactly is community readiness model? It's a model that has 9 stages of readiness. It measures 6 dimensions or aspects of a community And each dimension has a stage which has specific interventions that work for that stage. It integrates culture into the prevention process, and it's trying to implement something that the community is not ready to do, or, pardon me, trying to implement something that a community is not ready to do can be costly in both human and financial resources. For example, if I was to go and start needle exchange on my reserve and they're in total denial, you'd get a real big pushback. Whereas the reserve, two reserves about 40 minutes away, they're just like their level of community readiness is very high. When a community starts to think about an issue, they start to think about where they are, where they want to be, and how do they want to get there. So there's different strategies that they can take, and one of the processes that we've learned is utilizing community readiness is a great way to give them a roadmap. So again, it's a step-by-step process, and it's the process is actually quite takes a bit of work to do, but once you get the numbers in place and you identify exactly like you start to analyze the data, you quickly realize where your efforts should be. Like for example, if like leadership is not on board, there's strategies you can do to increase leadership's awareness about the issue. What does the model do? It facilitates community-based change, uses 9-stage multi-dimensional model. It provides an easy-to-follow roadmap for addressing Hep C prevention journey. But the other thing as well is it builds cooperations among systems and individuals. These are the 6 stages of readiness. So one is around community efforts. What is being done, like for instance, at the health centers. Sometimes there's a lot of work that is being done, but the community has no knowledge of those efforts. Sometimes leadership, as I mentioned, is not on board. The community climate, they may think that we're dealing with so many other issues that issue is not, we don't want to address that at this point. Community knowledge about the issue, and resources for prevention efforts. So the process for using the community readiness model is you identify the issue. So some of the issues that have been used around this is around HIV prevention, hepatitis C, suicide, and many other issues. This model has been used globally throughout the world. One of the first things as well is to define community. Community could be the organization itself, it could be a reserve, it could be the hepatitis C community, HIV community. Oh, sorry, I didn't realize that's going backwards. 4 minutes and 4, sorry, I better speed up here. And ultimately what you want to do is affect community change. This is was developed by CAN, and it's basically a cheat sheet. So once you've done all the work and identifying, it's quite a big process. You're interviewing 6 people. Once you've done all the work, it identifies like what strategies you can do with that specific stage of readiness. There is no like when you're interviewing people, they think that the higher stage, they want to give you numbers that are higher, but there is no right or wrong, I guess, or like if you, there's no, what you're wanting to do is you're just identifying the stage of readiness of a community to address this specific issue. Promising practice at Temiskaming First Nation. We began filming in Temiskaming, and they were using the community readiness model. They started in early 2000 or late 2015, 2016, and we finished the documentary in 2017. So first thing we obtained was support of the community. We got a band council resolution. We were there to film the initial stages of when they were initially doing their training of their staff, talking to the police, talking to community members. So we were there when they were doing that. They identified the issue as hepatitis C. They obtained the support of leadership, trained their staff. They increased knowledge and awareness of the issue within their community. Other successes. Last year, they do annual hepatitis C testing campaigns. Last year, 30 people got tested. Pardon me, I think their target was 30 people, but they ended up testing 35 people. So 35 people out of a community of 1,000. So I think that their testing campaigns are increasing each year. The community is fully supportive of harm reduction activities, such as clean needles to persons that are using drugs. And one of their biggest support is from obtaining people with lived experience as champions. So I just want to show you the trailer for our documentary to end off.
She said, I want to let you know we got your results back and you tested positive for hepatitis C.
We're getting more educated about this, and you know, there's more people dying from this than the AIDS now.
It's still very hard to talk about, but I feel I need to talk about it because this is how I'm healing myself. Those coaches would take me in their arms, go on at ceremonies, and they would give me that nurturing, they would give me that love, they would tell me that I was important, that I was beautiful, that I was strong. They gave me life.
So we'll be showing this the full documentary at the No Hep Village. So tomorrow, and you're more than welcome to join us. We'll have a couple showings at our booth, but as well we'll have it shown on the main stage tomorrow. So thank you so much for allowing me to be here.
Thank you to our two Canadian speakers, and we're now going to move south to the U.S. And our first speaker is Brian McMahon, who's actually going to be north for us from Alaska, and he has spent years working with the Alaska Native community, and he's going to be talking to us about control of hepatitis B and its consequences in the Alaska Native population.
Thanks, Jordan, and thank you, Alexandra, and others on the committee for inviting me to speak, and Malcolm also. I want to just mention that we had the second Indigenous Viral Hepatitis Conference held in Anchorage, and Alexandra and and Malcolm were both there, and it was great to have them. It was last August, and we had representatives from, I think, 16 nations around the world that were there, and almost 200 people. And there was a statement put out by the indigenous participants about viral hepatitis in indigenous populations and the need to address this. So what I did change my topic a little bit. I'm gonna talk about the success just in general in viral hepatitis in the Alaska Native population. So here's my disclosures. And so I'm gonna go through the hepatitis A, B, and C very briefly and show you what we've been able to accomplish over the last 20 to 30 years. And then I'll talk about the challenges that are associated with Hep C. And fortunately, we don't have Delta and hepatitis E in our population. So Alaska is a big, long territory. It's about 4,500 kilometers from east to west and about 15 from north to south. There's 300 communities. The Alaska Native population represents 20% of the population of Alaska. And they're divided into several groups, the Inuits, into 3 different groups, Yupik, Inupiaq, and Siberian. The Inupiaq speak the same language as the Canadian Inuits and the Greenlanders. We have 4 groups of Indians, Athabascan, Haida, Tlingit, Shimyan, who are the last 3 are down in the lower southeast part of Alaska. And then we have the Athabascan Indians, who are related to the Navajos in central Alaska. So our program is a program, I'm a hepatologist and an epidemiologist, and our program is involved in clinical care of liver disease, training and research. We manage cohorts of patients with hepatitis B, hepatitis C, also with autoimmune liver diseases. We have very high rates of primary biliary cholangitis, autoimmune hepatitis, hepatocellular carcinoma, and non-alcoholic and alcoholic fatty liver disease. We have clinics every day at our hospital, a tertiary care hospital in Anchorage, and then we go out and have field clinics in the hubs that have populations of from 5,000 to 50,000 in the rest of the state. But what I think is really important is what have I learned about viral hepatitis. So first of all, the most important thing I think starting out when I first got to Alaska is just through routine surveillance, we recognized that hepatitis A, B, and later on C were problems in Alaskan natives that disproportionately affected the Alaska Native population. We presented this information early on to the tribal boards. At that time, the government ran the healthcare system in Alaska, Indian Health Service, and also the communities and to the government. And we received the support from all of these organizations to do more studies and look at risk factors, transmission of hepatitis B initially prior to licensure of vaccine. And as soon as the vaccine was ready to go, we got permission from tribal approval to do a vaccine trial, initially for hepatitis B and later on for hepatitis E. We designed programs with tribal input for active participation to stop transmission of A and B in Alaska. And about that time, the federal government turned the entire healthcare system over to the Alaska Native population. And they are my bosses. They run the program completely. And it's been a boom to healthcare to have the indigenous population actually own and operate the healthcare system in Alaska. So then we worked with them to develop programs for chronic hepatitis B and C. So here's what happened with hepatitis A. We had these huge outbreaks with giant incidences of disease would occur about every 7 to 10 years. We did the registry trial in the US for children for the hepatitis A vaccine. And then we did a pre-licensure trial to try to stop that last epidemic by vaccinating susceptibles in 25 communities and stop the epidemic. Shortly after that, the vaccine became licensed, and the state of Alaska offered the vaccine to all children ages 2 to 18, and now it's 1 to 18, regardless of ethnicity. And so we don't have hepatitis A occurring anymore in the population. So what have I learned, what did we learn from that, I should say, is that in many countries with indigenous populations, as sanitation improves, asymptomatic infection does not occur in children anymore. And as a result, there's a large group of people that grow up without susceptible to who are susceptible to hepatitis A, and they have outbreaks can occur. Hepatitis A vaccine can be used to quickly stop these outbreaks with just one dose, has been seen recently even in the US in the homeless outbreaks that have occurred. And then to prevent future outbreaks, 2 doses of vaccine will work. And we have long studies looking at long-term protection of this vaccine, and we've got data out to 22 years showing this, that the antibody levels are still very high in people who are vaccinated as children. So with hepatitis B, we noticed when I first came to Alaska that there was a lot of hepatitis B going on in Western Alaska. Did some serosurveys to find high prevalences and also high rates of liver cancer, and even in children. And the liver cancer in children is what really turned the attention of the community, of the Alaska Native community, to the fact that this was a huge problem. Children are very valuable, and as you know, in all ethnicities, and this really turned the people on to say we got to do something about it. So Alaska Natives are the only non-indigenous population in the US that is endemic for HPV, and the Inuit up in northern Canada are also endemic for HPV. So we have 5 different genotypes in Alaska that came from different parts of the world. In Northwest Alaska, where genotype C predominates, it's primarily maternal transmission to children. In Southwest Alaska, it's primarily transmission under the age of 5 from open cuts and scratches. We did a vaccine trial in 1981, and then a huge outpouring of support from the Alaska Native corporations came, and they lobbied the government, and as a result of that, we got $9 million to go out and screen the entire population for hepatitis B. We screened 53,000 persons, which was 3/4 of the population, 90% in the endemic area. A lot of the screening was done by the Native Health corporations. We contracted to them. There have been no new cases of acute hepatitis B in children since 1980s, and no children under 20 with HBV infection. We also introduced newborn vaccination in 1983. And there's been no more cases of liver cancer in children. Here's the number of children we found, over 450 with the serosurvey that were positive for Hep B. There's no one under age 20 now that's positive for hepatitis B. Liver cancer rates were 10 times higher than what was seen in children in Taiwan. We've not seen a case of liver cancer in a child since 1999. And we also have shown from that very first trial that we conducted with 2 Alaska Native corporations in Western Alaska and continue to work with them on this trial, that the protection, both demonstration from humoral and cellular immunity, lasts for at least 30 years, and we now have 35-year data showing that the protection is still around 90%. We can demonstrate a recognition of immunity. Now, one of the problems is that when you do a successful vaccination program, those people who were infected as children, there's a lag period between the development of liver cancer and cirrhosis, and that usually begins to accelerate in the 3rd and 4th decades of life. So therefore, the impact on reduction of cirrhosis and liver cancer mortality, we're not going to see for a while after a successful vaccination program. We still have about 1,200 people with chronic hepatitis B. 3/4 of those live in rural communities, mostly in Western Alaska, and 80% of those patients are actually linked to care. Now, here's an example of a rural community in the Yukon River in the wintertime of about 500 people. There's no roads that go anywhere. The nearest hospital is 150 kilometers away by air. Many of the similarities that you see in Canada and other parts of the world. So we developed a registry. The registry automatically computerized sends out letters to hepatitis B carriers telling them to get their blood drawn every 6 months. The bloods is drawn by the community health practitioner. An indigenous person in the community receives a 16-week crash course on medical care. They draw the blood, spin it down. We send them lab slips with barcodes on it. They send it to our hospital. We run the tests, and we review those tests, including liver functions, AFP, and HBV DNA. We found that AFP is a terrible test for diagnosing liver cancer, but has very good negative predictive value, so that we can use AFP to determine who needs to come in for ultrasound. Despite that fact, we also send letters to everyone for ultrasound examination for all males over 40, females over 50, those with genotype F, which is the genotype that causes cancer in children, and those with cirrhosis or a family history of HCC. We review all these results, and then we make decisions about what to do with the patients after that. The problem with even sending these letters out with ultrasound is that people can't afford to fly every 6 months into a facility to get ultrasound unless they have some sort of insurance support. So here's our linkage to care. We know everybody with hepatitis B in the population. 93% of them have agreed to participate in the program. 63% of those have been seen within the past year. And of those, because most of them have seroconverted from E to anti-E over the years, currently only about 10% meet ASLD criteria for treatment. 83% of those are on antiviral therapy, and about half of those, or 68%, are virus negative and normal ALT. So with hepatitis C, as we've heard, there's two epidemics that have occurred in Alaska. The epidemic from the 60s, 70s, and 80s. And those patients are the baby boomers, and then the current epidemic that's going on with the opioid drug use. And I might mention that of the baby boomers you identified, half of those actually have advanced fibrosis or cirrhosis. So you can see there's very high rates of hepatitis C increase in indigenous populations. That's the blue line that you see there compared to other ethnic groups. We've seen a dramatic increase in the number of HCV cases that we're identifying in post-baby boomers. Baby boomer identifications remain pretty constant. And the liver-related death to hepatitis C is very high in American Indians and Alaskan Natives. So we, again, link our patients to care using the same sort of a registry. We try to get them seen at least once a year in one of our liver clinics. We use a variety of methods to treat our patients: video clinics, telephone consultations, Project Echo, et cetera. And our goal is to evaluate everybody with Hep C, and all patients are treated regardless of their ability to pay. So here's our linkage to care for Hep C. We've done over 30,000 screens. We've identified, I can't see the numbers there, but something like 2,000 people. 98% are linked to care. 62% of those, or 98% I should say, have had HCV RNA testing. 62% are positive, 28%, or of those, 83% are in the queue or been treated or being treated for HepDAs. We've treated about 700 people thus far. So how have we been able to do this? Well, it's a work in progress. We've developed a training session for primary care providers to learn how to treat hepatitis C. We have a website with a lot of information. I'm going to share that with you. We use, as I said, a variety of techniques, including telemedicine and other means to reach our patients. But we've discovered, and one thing I think that's really as important is hepatitis C is not limited to indigenous populations. It's really a community-wide problem. And so we realize that even if we do a good job in our own indigenous population patients, then we still have not solved the problem, and reinfection can easily occur unless we address the whole community. So we formed a group called the HOG, the Hepatitis Alaska Working Group, and we get together on a regular basis and try to plan programs to try to eliminate hepatitis C in the population, and I'm just listing there a few of the things that we've done. So this is our website, and please go on there. I want to take a minute or a few seconds to tell you about it. It was funded by HHS. It's updated constantly. It has portals for both patients and providers. It's used by a lot of populations in the lower 48, including a lot of American Indian populations. Anybody can get on, both the provider and the patient. It's free. and there's a lot of information, so I recommend that you take a look at that. Thank you very much. And here's a picture of Denali. Denali is the highest mountain in North America, almost 7,000 meters. Used to be called Mount McKinley, but fortunately our former president changed the name to the Athabascan name, which is the high one. That's the Athabascan name, Denali. And our current president threatens to reverse it back, but our Republican senators tell him that he's in big trouble if he does. So thank you very much.
You want to introduce?
Okay, well, it's my pleasure to introduce our next speaker, who I've known for the last several years, who's done a fantastic job with the Cherokee Nation, Jorge Mira. Now, Jorge is an infectious disease doctor who's developed a very comprehensive program to eliminate hepatitis C in the Cherokee Nation.
Thank you very much. I want to thank the organizers for inviting me today, and I will be talking about our hepatitis C elimination program. These are my disclosures. I also want to disclose that I'm an Argentinian citizen, and we are playing Iceland on Saturday. So we will probably beat them on the Hep C and soccer challenge. The outline of my presentation will be an overview of the Cherokee Nation Health Services. I'll talk about our successes, failures, and achievements in the Hep C elimination program, and then some final thoughts. So the Cherokee Nation is a sovereign nation within a nation. It's located in the northeastern part of Oklahoma. It has 350,000 citizens, but we take care of the 130,000 citizens that live in the area. We have one central hospital in the capital, which is Tahlequah, and 8 outlying clinics, which are the red crosses you see in the Cherokee Nation map there, which are community health centers. This is a tribal health system, and it's the largest tribal health system in the United States. And I put there the number 80,928 patients come to our system in around a 3-year period, because it's an important number that I'll come back to in the presentation. So in 2015, we decided to embark in a hepatitis C elimination program. I coined it microelimination here, but at that time, the term did not exist. And the first thing we did is put together our cascade of care. And I will show you my emotional perception of my cascade when I first saw the results. And I feel I probably am in that little red wrap on the top with my nurse. We were only 2 providers handling hepatitis C. But as time went by, we came to a more soothing image and situation. And in the next few minutes, what I'll do is basically show you what interventions we made. And this might be a little bit of a spoiler, because the summary of the presentation is on that arrow. And I will go through it briefly. So this was the actual cascade in 2015. And I remember presenting this in a meeting in San Francisco with Dr. Feld was there. And we estimated that we had 1,892 infected patients in our Cherokee community, of which we only had detected 21%. So that first arrow, the big drop, is what I felt, and showed you the picture of being on that graph falling through that steep cascade. So screening was our major problem. Although we had problems all along the cascade, that was the major issue we had to tackle initially. So how did we get from this cascade to this cascade, which is our December of 2017 cascade of care, in which you see a much smoother ride, although there's problems, a little bit of problems everywhere, but much better than what we initially started with. So 2 critical concepts on hepatitis C elimination. You have 2 big target populations to address. The first one is an older population in the United States coined as the baby boomers, born between 1945 and 1965. In Canada, they have expanded screening recently to those born in 1975. And these are the group of people who are at risk for developing cirrhosis, or if they already have cirrhosis, developing complications of cirrhosis. Very few of them will be transmitting the disease. Some can, there's some overlap. But I also included people that have been infected for 20 years and do not meet the age criteria of the screening programs in the US and maybe Canada. People can get infected at very young ages or have multiple liver comorbidities, and they will be developing cirrhosis, and we will not be able to detect them, and we only follow the strict age-targeted screening. The second group is the most important group to achieve elimination, which is those who are transmitting the disease. And in the United States, 90% of the people who are transmitting the disease belong to the people who inject drug category. And there's three main interventions. One is treatment as prevention, needle and harm reduction programs to decrease transmission. So our first goal was to secure political commitment, and that is like the continuum of care of the cascade. It's not something you do on day one, you do it every single day that you're working in your institution. And in 2017, the gentleman in the pink shirt is Chief Bill John Baker. He's the chief of the Cherokee Nation, and he proclaimed October 31st as being the Hepatitis C Elimination Awareness Day for the Cherokee Nation. So when we're trying to detect people who have hepatitis C, there's two groups, as I've mentioned. The people who are injecting drugs, which are represented in this circle. And if you review the literature, where can you access these people to screen them and detect hepatitis C and eventually treat them? So you can do it when they access medically assisted treatment programs, when they are in prison, or when they are accessing a needle and syringe program. Unfortunately, in Cherokee Nation, these services were not available in 2015, none of them. So we had to think a little bit outside the box, and we included not only those who are injecting drugs, but all people who are chronically infected and maybe not transmitting as a big population that we need to detect. Now, we do know that this population belongs to the 80,000 so Native Americans that access our health system. So what we decided to do as our main intervention for detecting these two populations was to implement universal screening. The target was, let's screen everybody who hits the health system and see if we can have a good chance of detecting the people who have hepatitis C. So what I'm going to show you in this slide is the 3 periods of screening in the Cherokee Nation going back to 2006, the interventions that we implemented and the results. So the first period, 2006 through 2012, as you can see, we were only screening high-risk patients as perceived by the provider or had abnormal LFTs. And when you look at the fourth column, the number of patients screened per month average was about 57 patients. On our second period, 2012 through 2015, we incorporated the CDC recommendation to screen baby boomers. We helped our providers by implementing electronic health record reminders, and we did several workshops educating all the providers in the health system on why and how to screen for hepatitis C, interpret the results, and refer them to us. And you can see that we had increased about 7-fold. We had 357 patients screened per month. And finally, when we started our elimination program, in 2015, we incorporated universal screening, everybody 20 to 69 years old, and we also expanded screening to sites that go beyond primary care, like urgent care, emergency department, OBGYN service, dental clinics screen for hepatitis C, and we also implemented a strategy called lab trigger screening, which I don't have time to explain in detail, but I'd be happy if anybody has any questions. And when you look at the fourth column, again, our screening rates went up to 905 patients per month, which is about almost 20 times more than we were screening in the first period. All of these patients are unique patients to all the periods in this graph. So at the end, we have screened 54% of all our target population, which is patients 20 to 69 years old, as of December of 17. So right now, if we concentrate on that last period, 2015 through 2017, we have screened 38,591 unique patients in that last period with a prevalence of hepatitis C of 3.6%. This is seroprevalence. And in the graph, you have the different prevalence according to gender and to age. And the most important finding for us was that 57% of all the patients that were newly diagnosed in the last 2 years were younger than baby boomers, which reinforces our universal screening policy in the Cherokee Nation. Okay, so our first goal was screening, and I talked a little bit about that. Our second goal was screening. Our third goal is once we patient tests positive, we need to engage them in care, treat them, and cure them. And in the bottom left corner of the slide, you will see which were our goals. 85% of linkage to care of those who tested positive, 85 started in treatment, and 85% cure rates. These were arbitrary numbers we decided before the WHO came out with their recommendations. And as you can see in the 3 blocks, before the patient's being evaluated, during evaluation, and after treatment initiation, there's multiple persons that need to intervene. A lot of human resources needed to those patients who are seropositive to get them an appointment in the clinic. Once they're in the clinic, we run them through a alcohol and drug counselor to refer them to the specialty services if they need them. But the most important thing, we use the Project ECHO from the University of New Mexico to train all our clinical providers to evaluate and treat hepatitis C. And at the end, once the patient starts treatment, we have clinical case managers, pharmacists, and community health workers, even doing direct observed therapy in those more difficult to treat patients. So this is a result of all that human resource intervention. If you look in 2014, when DAAs were available, I was the only one treating hepatitis C. When we started Project ECHO, we trained 7 providers in the outlying clinics. In the red line, you can see the cumulative number of cases of patients treated. In the columns is the number of patients treated every 3 months. And as time went by, when we started the elimination program, we trained 24 providers who are treating hepatitis C across the nation. So only 1 specialist, which is me, and a very robust primary care clinical force. It's important to mention that when we looked at cure rates according to provider type, it was exactly the same. And more than 90% of the patients who are being treated are cured. So the message of this is that primary care involvement is critical for our hepatitis C elimination program. Finally, on roll number 4, to reduce the incidence of new infections, we did a public health campaign that was short-lived, but very intense and productive during the 3 or 4 weeks we made it. It was through social media, radio, etc. We also did a provider education training through workshops held across the 8 outlying clinics, reinforcing hepatitis C evaluation and treatment. And we implemented contact tracing on those people diagnosed with acute HCV or people who were injecting drugs. And finally, we started to try to expand our harm reduction programs. The main problem we have is that in Oklahoma, needle and syringe programs are illegal. So that's the only thing we have not been able to implement, and we're working very hard to solve this issue. We have started expanding our medical assisted treatments with opiate substitution. So this is the cascade, the results of our efforts so far. As I mentioned, we had 85% goals across the cascade in a 3-year period. It should end in October of this year. I don't think we'll get to the 85 in every place, but we've screened so far 54% of the target population. Of those screened, 75% have been evaluated by a hepatitis C provider, and of those, 71% have been started on treatment. And those who have completed treatment, and we have data available, 96% cure rates. So barriers and solutions for our program in particular. The first one is the lack of harm reduction services. As I mentioned, no needle and syringe services. I have a meeting actually next week with the Chief Bill John Baker to see if the Cherokee Nation, since it's a sovereign nation, can change the local laws and we can implement needle and syringe programs. We need to engage more patients in care. We need to start screening in areas where the patients do not access the health system. Go to the community, and that's part of our plan this year. We need a lot of human resources to track people. We need people to track people. And that takes a big effort and funding. And that data collection has been a nightmare for us. We are not a university. We are not a research institution. So collecting the data, cleaning the data, analyzing the data has been pretty cumbersome. And that's why we've been 3 years on a program without good results that have not been published yet. So any area that starts an elimination program needs to address this at the beginning and get support, or else your results, good or bad, will not be shared, with other programs. And finally, although we are very lucky that we do have access to medications, to DAAs, it's not as easy as prescribing a statin and having the patient go to the pharmacy and get it and the same day get the treatment. It takes several weeks and sometimes months to get DAAs for our patients. and we need more government support or subsidies so that treatment can be delivered as any other treatment that we deliver for other patients like HIV or diabetes, et cetera. So my final thoughts is that the Cherokee Nation Health Service HCV elimination program is based on universal screening. That's the most important component, I believe. A robust primary care force based or using Project ECHO as their training platform, and harm reduction interventions. That the only one that we have been very successful implementing is treatment as prevention, because everybody who walks through our door is offered hepatitis C treatment. The second is the cascade of care is very useful to know where you are and where you need to go, and so you can plan for the interventions necessary to get there. And the main barrier for programs that have access to DAAs like ours is the other components of the cascade. So having the DAAs is crucial, but it doesn't cut it. You need to screen people, you need to engage them in care, and you need providers to treat those patients. And finally, moving forward, we need to measure our success in an objective way. WHO has given out guidelines of 65% reduction in mortality by year 2030 and 90% reduction in incidence. And like we saw in the presentation on the opening session today, this is more easier said than done. And those measures are very difficult to obtain, although we are working with our health department to see if they can help us with this task. And I just want to acknowledge all the people that have helped us and the institutions that have helped us. And Whitney Essex, which is sitting right there, and she helped me put together a presentation. She's our program coordinator for the Cherokee Nation Hep C elimination program. Thank you.
Very impressive results. And now we're going to keep moving south, and then we'll call on Martin Tagli from Peru to talk about the challenges of addressing viral hepatitis in the indigenous populations in South America.
Thank you. On behalf of the Latin American Association for the Study of the Liver, I'd like to thank the organizers of this meeting for inviting me. As an introduction, I should mention that the Andes region is the largest mountain range on Earth, measuring more than 7,000 kilometers long, and it crosses 7 countries: Venezuela, Colombia, Ecuador, Peru, Bolivia, Chile, and Argentina. This South American map shows the 7 countries I was mentioning: Venezuela, Colombia, Ecuador, and this also Chile and Argentina in dark blue. For the purposes of this analysis, I'm not going to include Argentina and Chile because they behave more like European countries regarding ethnic and cultural reasons. So I'm going to focus on the data shown in Venezuela, Colombia, Ecuador, Peru, and Bolivia as a whole, considered an Andean region. I'm going to base my talk on an important document, a very thorough document issued by the WHO in 2016, studying hepatitis B and C realities throughout America, from Canada to Argentina. And also, last year, there was an important document issued by PAHO and WHO also updating this information and providing more relevant data. And for the purpose of this talk, I've isolated only what pertains to these 5 countries. Despite the fact that hepatitis B and hepatitis C were discovered 3 and 4 decades ago, it wasn't until the late 90s or even the late 2000s that the Andean countries have embraced blood donor policies to screen their people who went to the blood banks, as you can see in this table. For example, in Bolivia, the year achieved 100% coverage for screening in blood banks was in 2007, too delayed. Now, Peru is the largest country of the Andean region and has also the largest proportion of Andes mountains in its region. And also, there's a lot of heterogeneity between the departments of Peru. In yellow, in this map, you can see the coast department harboring the urban cities, especially Lima, the capital city. Then in brown, you have the Andes departments, which is the poorest area of the country. And in green, you have the jungle or the Amazonian basin departments of Peru. And this graphic reflects the heterogeneity among the different departments in Peru. This is data from the blood bank results from the last 2 years in Peru, more than 1 million units screened. This is very new, fresh data I'm bringing to you today. And we have divided the graphic in three parts. As you see in the far left, the coast departments in Peru, hepatitis C has the highest prevalence, much more than hepatitis B and HIV in orange bars. In the Andes departments in Peru, the situation is quite different, and being hepatitis B and hepatitis C almost equally prevalent in blood banks. And in the jungle, in the Amazonian basin departments, hepatitis B is slightly predominant compared to hepatitis C and HIV. But overall, because of the high prevalence of hepatitis C in the coast, we can see that overall in Peru, over 1 million units screened in the past 2 years, hepatitis C is a more prevalent virus in our country. And please remember that for the data I'm going to show you later. Now, the countries in the Andean regions are very heterogeneous, not only because of the ethnical and racial and cultural reasons, but also because of their policies regarding how they handle official notification of viral hepatitis B and hepatitis C. There is no official data from Bolivia and Venezuela, but for example, Colombia is the only country of the region officially notifying cases of hepatitis B and C, acute and chronic. Ecuador, for example, officially notifies the authorities only acute cases of B and C, but not chronic cases. And Peru has only been paying attention so far to hepatitis B, acute and chronic, but neglecting hepatitis C, acute and chronic. But I think that policy is going to change very shortly in Peru. This is a graphic obtained from the WHO webpage showing the number of countries having introduced hepatitis B vaccine and global infant coverage for the 3 doses. And the number of countries doing that, achieving that goal in 2016 was 186 countries. And here in dark blue, you can see the countries that have achieved the milestone of achieving more than 90% coverage of children. And in the Andes region, only Colombia and Bolivia have achieved that 90% milestone. Venezuela, Ecuador, and Peru are still a little behind in the 80 to 89% range of vaccination. Despite that, I think we have been doing a very decent job in controlling and preventing hepatitis B in the Andean region in general as a whole. For example, the 5 countries have a Ministry of Health structure especially dedicated to control and prevent hepatitis B and HIV. Usually it's coupled with HIV control. We all, except for Venezuela, routinely screening pregnant women, and there's an offering for HBIC for exposed children, and we all have in the Andean countries hepatitis B vaccine in our immunization schedules. So as a result of this successful policy, we have made some progress here. This is a map back in 1996 showing that the Andean countries belong to the highly endemic area with more than 8% prevalence of hepatitis B surface antigen positivity. And that map has changed dramatically, and now in 2013, we have changed, and now we belong to the low or to intermediate areas of prevalence of hepatitis B surface antigen, which is 2 to 4.9%. Huanta is a very small and poor town located in Ayacucho, one of the departments located in the Andean region in Peru. And because of the high incidence of vertical transmission in that area, in Ayacucho and in Peruvian Andes, the prevalence of hepatitis B surface antigen in children between 3 and 6 years is around 10% back in 1991. And the prevalence of anti-Q was exceeding 30, 40, or 50% in some cases, very prevalent disease in this area. What happened in 1991, Huanta and the whole department of Ayacucho underwent a very intense pilot program of vaccination for hepatitis B. And when they went back in 1997, they found that the prevalence of hepatitis B surface antigen in this age group between 3 and 4 years old became from 10% to 0%. And the prevalence of anti-core antibody was reduced from 28% to 3.6% in that area, reflecting a very successful vaccination campaign. Another way of looking at the same aspect was shown in Abancay. Abancay is a very, very poor region also in the Andes Mountains in Peru, next to Ayacucho. And they looked at death certificates. This was published last year in the Journal of Vaccine. Death certificate data in the decade of 60s, 70s, and 80s showing fulminant hepatitis B, death from cirrhosis or death from cancer. And after the vaccination campaign in 1991, the rate of fulminant hepatitis became almost to zero, and very few cases of cirrhosis in this particular area in Peru. Now, when we look at the data from 1990 to 2013 in the 5 Andean countries, the picture doesn't look too good. The incidence of death from hepatitis B and hepatitis C cirrhosis in the Andean countries has been steadily increasing, especially in Peru. And if you look carefully at the numbers in the bars, for every country, hepatitis B as a cause of cirrhosis and death has been, hepatitis C is more prevalent than hepatitis C as a cause of cirrhosis and death throughout the countries. Regarding the policies and practices for hepatitis B and hepatitis C, now speaking about diagnosis and treatment in the Andean region, we all have serological testing for hepatitis B and hepatitis C, and except for Venezuela, there's availability of nucleic acid testing such as HBV DNA or HCV RNA. However, when we come to hepatitis C policies, except for Venezuela, the countries recommend direct-acting antivirals as a first-line therapy for hepatitis C. However, when it comes to public funding of these drugs, only Colombia is funding both hepatitis B and hepatitis C, but the rest of the countries have funding only for hepatitis B. And I think this is a matter of economics and costs of therapy, which we can discuss in the panel later on. Tenofovir and entecavir, as of course in the more developed countries, are offered to the people in these countries mainly. Now let's switch gears to talk about cancer in the region. And when we talk about the Andean region, by far you can see in that table that Peru has the largest incidence of hepatitis B-related cancer of the liver. And the mortality rates from hepatocellular carcinoma is also high when it comes to related with hepatitis B. For example, you can see in the table that the mortality from hepatitis B-related cancer is higher in Peru, but in Colombia, the picture is different. Colombia has the highest rate of mortality from hepatitis C. That's a big difference between the two countries. So let's take a close look, just to finish my talk, what's happening in Peru regarding hepatocellular carcinoma. I'm going to show you the largest series of cancer in the Andean region. And this is a large study conducted in a big reference hospital in Lima called the National Institute of Cancer, looking at over 1,500 cases between 1997 and 2010. And it's a retrospective review of charts. One of the striking features of this study was the bimodal occurrence of cancer in this population. We have a peak incidence at 25 years old and another peak at 64 years old. This is very unique in epidemiology of cancer. Another very striking feature is that, as opposed to what happens in the developed world, in which 90% of the cases of hepatocellular carcinoma are occurring in cirrhotic people, here in our country, the 90% of cases are occurring in non-cirrhotic patients. Only 1/3 of cases harbor hepatitis B, and less than 2% harbor hepatitis C. So let's analyze what happened with a hepatitis B patient with cancer in our series. When we look at those 452 patients, most of them are young. The mean age of those people with cancer and hepatitis B is 25 years old. And when we take a look at the 1.8% of people with cancer and hepatitis C, it's a different picture. 70% of those patients are older, a mean age of 64 years old, reflecting a different epidemiology between hepatitis B and hepatitis C causing cancer in Peru. So in conclusion, the Andean region is very heterogeneous in many aspects, and the policies related to viral hepatitis may vary from country to country. With respect to hepatitis B, there's been a notorious progress, and we have decreased the HBsAg prevalence throughout the Andean region. Despite being the main cause of mortality in cirrhotics, as we have shown today, the prevalence and policies of diagnosis and control of hepatitis C has been neglected until recently, and that might change in the next few months or years. Peru has a unique hepatoma epidemiology, being the country with the highest incidence and mortality in the region. And universal access to hepatitis C detection and treatment remain the biggest challenge to achieve a desired goal to eliminate hepatitis in the 2030. I would like to take advantage of this opportunity to invite you to a meeting we're holding of the ALE in Punta Cana, in Dominican Republic. It's going to be a very nice meeting with excellent speakers in September, to 20 to 23rd of September this year. I want to thank you for your attention.
For that really excellent talk. And our next speaker is Nick Walsh, who is the director of PAHO Viral Hepatitis Activities. And he's going to talk about, he's also with the WHO, PAHO's efforts to address viral hepatitis in indigenous communities in the Americas.
Before we actually go to Nick's talk, sorry, Ryan,
sorry.
Raimundo Parana was going to be presenting on challenges with the indigenous communities and viral hepatitis in the Amazon basin of Brazil. Unfortunately, he was unable to attend due to a last-minute medical issue in a colleague. But in his stead, we have a video which comes from the Special Secretariat of Indigenous Health in the Ministry of Health of Brazil. And this is also called CESAI, and a special thank you to Luana Faria for his efforts in putting this together. And so we're going to show this video now, if we could cue the movie. Thanks.
A CESAI, Secretaria Especial de Saúde Indígena do Ministério da Saúde, foi criada em 2010 como uma conquista dos povos indígenas brasileiros. A saúde pública do Brasil é organizada pelo Sistema Único de Saúde e a população indígena brasileira é a única que conta com um subsistema próprio administrado pela CESAI. A Secretaria também é responsável por coordenar a Política Nacional de Atenção à Saúde dos Povos Indígenas desde 1999. A CESAI atende de forma diferenciada e qualificada aproximadamente 760 mil índios que vivem em terras indígenas que compõem um universo de 305 etnias e 274 línguas diferentes. Além desses serviços de atenção primária, a CESAI promove a articulação com os serviços de média e alta complexidade, de modo a atender integralmente às necessidades dos povos indígenas. Importante dizer que a Secretaria também provê logística de transporte, comunicação, gestão de medicamentos e executa obras e serviços de saneamento nas terras indígenas, completando assim a sua missão de levar uma saúde de qualidade aos povos indígenas brasileiros.
Em 2017, foram realizados mais de 4 milhões de atendimentos nas mais de 5.500 aldeias, em uma extensão territorial de mais de 1 milhão de quilômetros quadrados. Os registros desses serviços são compilados em um sistema específico para dados de saúde indígena, chamado CIASE, sob a gerência da CESAI.
Quem que está E aí eu comecei a pedir que meus ancestrais me dissessem o que fazer. O que fazer, como fazer. Porque eu precisava de uma resposta deles. Porque essa é a minha raiz. Né? É buscar a resposta com meus ancestrais. E depois de uma semana, eu tive a resposta, reuni meus filhos, que todo mundo ficou muito desesperado. Aí eu disse que naquele dia não tinha mais choro, nem doença, que eu ia, que era só mais um desafio na minha vida. Retornei para minha aldeia, cheguei, conversei com o meu cacique, meu pajé, eu disse, tá, tem essa doença no meu corpo, e nós temos que fazer isso, isso e isso. Aí ele disse, nós temos que fazer isso, isso, isso e mais isso. Aí eu disse, então vamos. E nós fomos para a mata. A primeira coisa que eu fiz foi tomar um banho muito grande no rio, dentro da mata. E depois me entreguei para a mãe natureza e fomos atrás das raízes, do cipó, das folhas. Eu sei que eu tenho que tomar o remédio do branco, eu tenho esse entendimento, mas eu preciso também da minha medicina, que é para não me deixar doente com o remédio do branco.
No caso das hepatites virais, a taxa de detecção da hepatite B na população indígena é quase o dobro da taxa da população não indígena. Nesse contexto, a CESAI tem envidado esforços para ofertar tratamento diagnóstico, imunizar a população afetada e articular com as próprias comunidades estratégias de educação em saúde, promoção da saúde e prevenção de doenças e agravos.
Very interesting. Thank you, and we'll pass on our thanks to Luana for sending that to us to give us some sense of the work that they're doing in Brazil in the Ministry of Health. And now we will move on to the next presentation from PAHO to give us a sense of really the whole region and some of the efforts that PAHO is making to address viral hepatitis in indigenous communities specifically.
Great. Well, thanks very much. I just first of all like to acknowledge the traditional owners of the land on which we stand. So I work as a regional advisor in the Pan-American Health Organization, which is the regional office for the World Health Organization based in Washington, D.C. I'm going to talk about PAHO efforts to address viral hepatitis among indigenous communities in the area. I just want to say that this is something we really just recently began on last year. And so we're trying to articulate exactly what we are doing, and I'm going to present some of these activities to you now. So we have already, I outlined the talk here, so we already have an elimination agenda for hepatitis within the communicable disease elimination agenda, and Godfrey talked about this earlier this morning, or this afternoon. We have several activities relating to Indigenous health within the Pan-American Health Organization across the region. So what we want to do is really join these two agendas. So how do we address communicable diseases among Indigenous peoples through the elimination lens? So I've got some acknowledgements, colleagues in Washington and in the region, and of course in Geneva as well. some of the slides in the presentation, but just briefly, I think everybody knows that, the sustainable goals, number 3, was ratified in 2015, now 3 years ago almost, and it stated that by 2030 we would end the epidemics of AIDS, tuberculosis, malaria, NTDs, and combat hepatitis. Combat was a little bit disappointing. We would want to end it by 2030, but we got the word combat in the end. It's better than nothing. But that was really the first sort of global agreement on hepatitis, which was followed fairly shortly by the global strategy, the global health sector strategy on viral hepatitis, which had the vision where we would have a world where viral hepatitis transmission is halted and everyone living with viral hepatitis has access to safe, affordable, and effective prevention, care, and treatment services. And there's been a lot of talk in this session and the previous session on the goal that we would eliminate viral hepatitis as a major public health threat by 2030. Now that we have a regional action plan in this region, as Godfried had mentioned, all regions have regional action plans, and the regional action plan is aligned to the goals of the global strategy. So one of the issues that action on hepatitis presents is that there are several populations where we really do need to take a public health approach in particular, and this includes, among other populations, Indigenous peoples. So we really did not know the burden of hepatitis among Indigenous peoples in this region. There are 1 billion people in the region, and there are 50 million people, Indigenous people in this region. We didn't know this. We didn't know what the data was. So we actually commissioned a systematic review of the literature. I'm going to show you some of these results. I mean, some of this has already been presented by Brian, Jorge, and Martin, but we found that there were, in the literature, at least 21 studies having some data on the burden of hepatitis B and C among Indigenous peoples or Afro-descended populations. This systematic review was actually looking at Afro-descended populations as well. And the anti-core hepatitis B prevalence ranged from 0 in some populations to 80%. Surface antigen hepatitis B prevalence from 0 to 30%, and anti-HCV prevalence from 0 to 6% among different Indigenous communities in different countries of the region. So if you put this on a graph, is there a point? Can I point or? Okay, so yeah. So listen, what I've done here is just group this into countries. So we've got Argentina, the data from Argentina up the top, then we have 2 studies from Brazil. Colombia, we have 2 studies. We have 2 studies from Mexico, Peru, and 3 studies at the bottom of Venezuela. I think, the major point here is that in blue is the general population prevalence. And in red is the prevalence among Indigenous communities in these particular studies. And so the bottom line is the prevalence is much higher if you want to examine what the situation is regarding hepatitis B. Very little data available on hepatitis C. We only found 3 studies, 1 in Mexico, 1 in Colombia, and 1 in Brazil. The Brazilian study showed a prevalence which was lower than the general population prevalence, but the prevalence in the Colombian study in the Amazon and in one particular Indigenous community in Mexico was substantially higher than the general population. So Delta is really interesting. We really don't have much data on this. There are some pockets of high Delta prevalence, and one of the around the world, one of the pockets is in the Amazon region. The distribution of Delta in the Amazon region is heterogeneous. Some communities with no Delta in the hepatitis B positive population, and some communities with up to 20%, possibly more, prevalence of Delta in those populations, which predominantly are Indigenous. So just more broadly, what's PAHO done to support Indigenous health, action to address health burden among Indigenous communities in the Americas? I mentioned the systematic review just to understand what's the burden of communicable diseases, the major communicable diseases, including hepatitis in the region. Last year, we included Indigenous representation into our regional strategic advisory group for HIV and hepatitis, and in fact, that person was from the Canadian Aboriginal AIDS Network, so we're grateful to the participation of him in that group, and I think that's that's a small step, but it does signify that we would like to engage. We assisted an Indigenous youth health group to develop a Indigenous youth health plan for Latin America and the Caribbean, and that was in late 2017. And finally, this idea to join the elimination agendas, or the agendas of elimination of communicable diseases and in the Indigenous health agenda. So, as I said before, we've got 50 million people in the region who would be considered Indigenous, belonging to around 400 different ethnic groups. There's a lot of socioeconomic and political challenges that Indigenous people face in this region. Mostly on the vulnerable side of the equation, almost all on the vulnerable side of the equation, no matter the country. We really don't have a lot of data, and this is a problem because it's hard to advocate without data. There has been some normative work through PAHO and WHO to address some of the health gaps which are determined by ethnicity. There was a Healthy Indigenous Peoples in the Americas resolution that went to the Directing Council in the 1990s, and later in 2006 we had a Health and Human Rights resolution in 2010, which addressed some of the questions of vulnerability. Of course, everything today, all of our work in WHO and PAHO needs to be seen really through the lens of universal access to health and health coverage. That's where we are. We're not vertical. We're integrated with the general health system. And so the strategy for universal access to health and universal health coverage, which was adopted just a couple of years ago, is really important for us in terms of action on hepatitis. Finally, last year there was a policy on ethnicity and health, which was approved by the Directing Council of the Member States of the Americas, which specifically addressed vulnerable populations, including the health of Indigenous peoples in this region. That policy, and I just want to mention one thing, because I'm talking very much about policies, broad level action. What you've seen in the other presentations very much been in the field, hands-on, connecting with the community. And I think, there's a real partnership that happens here. We need both sides of the equation. We need to change national policy. We also need people on the ground working face-to-face with vulnerable communities. But this policy on ethnicity and health has 5 areas of work. The generation of evidence, because we need the data to be able to advocate, to know what to do, to know how we're doing. Policy action, of course. Participation and strategic partnerships with vulnerable communities, including Indigenous peoples. Recognition of ancestral knowledge, traditional and complementary medicine, as was mentioned in the video. And capacity development at all levels. But I'd just like to spend, I've only got, I think this is my second last slide, just a second just to explain to you what we're trying to do at the moment. We've got the elimination agenda, we've got vulnerable populations, including health gaps, comparing the Indigenous population to the mainstream populations in many countries across the region. But what we're proposing is, and we've developed a proposal, and we're looking for partners on this, a 3-year inter-country initiative to operationalize the newly endorsed PAHO policy on ethnicity and health within the elimination agenda. So we take the policy on ethnicity and health, we take the elimination agenda for hepatitis, for other communicable diseases, put them together, operationalize it in the country, take it to the country. What, for example, in one country, do you have to do strategically and what do you have to implement to be able to reach some of these elimination goals with respect to Indigenous communities? We're talking currently with Peru And with the El Chaco area, which is an area sort of that sits in the middle of South America, including part of Bolivia, Paraguay, and Argentina. And we have been talking also with potentially connecting Brazil, because Brazil, as you saw in the video, has a strong interest in indigenous health. So this would enhance the health sector response to these communicable diseases through focused, inclusive, participative, and culturally sensitive interventions for indigenous peoples for the major communicable diseases, HIV, TB, and Hep. So this includes hepatitis. And we will ultimately be working towards the elimination of these diseases as public health problems among indigenous peoples. So this is really a micro-elimination agenda combined with national elimination agendas. Now this is in developmental stage. We are certainly looking for funding. We're looking for partnerships. We'd like you to join us. We do have some funding at the moment, and we do plan to go to Peru and in the El Chaco area in the next few months. But I just want to highlight this. This is one initiative. It's high level, it's political, but it's policy driven, but it potentially, we think this is an exciting area. So just in summary, we've had recent engagement between WHO, PAHO, indigenous communities. We need to do more of this. We've got the opportunity now to broaden the elimination agenda to include indigenous communities in this region. It's already happened. It was highlighted, in Cherokee Nation very well, and Brian's talk about Alaska. But we need national plans to include indigenous people, data and reporting systems, and improved understanding of the response. This needs to be collaborative. So emails there, reach out, join us, and we look forward to working with you. Thank you.
So if we can call all the speakers up, and we'll just grab a couple more chairs, and we'll have a few minutes
Si
for
tenemos preguntas,
discussion
por favor, si las
or,
pueden enviar al podium, levantar la mano para que alguien pueda pasar a recogerlas.
And I believe we can take questions from the Mexican group as well. We're gonna, I know that we are now, we went a little over time because we started a little late, and we are eating into the opening reception. So I understand that, but I do think it would be nice to have a few questions for our speakers if there are people that have some questions for them. Eamon's on his way.
Hello? Yes, can you hear me?
Yes.
From Mexico. Yes, I'm Dr. Sonia Roman from Mexico. I would like to congratulate all the speakers for such wonderful conference. And I have one or two questions for the audience, for the speakers. In Mexico, we have 15 to 20 million indigenous people, native people, divided in 62 ethnic groups, which are dispersed throughout the country. They are not concentrated in one geographic region. In general, hepatitis B is considered as low prevalence, but we know by different research studies that it may be higher. In your experience, where could we begin to do more screening or universal screening for these groups? What would you recommend?
Well, this is Brian McMahon, and I also want to congratulate Mexico, Canada, as well as my own country for winning the World Cup in 2026. It's going to be exciting to partner with all of you on the World Cup. So I think one of the ways you can get some information, two ways to get data is, one is to start screening all pregnant women, and then you can get an idea of the prevalence of hepatitis B in pregnant women. And then also screening, getting data from the blood banks, because I'm sure that in Mexico you are screening blood donors.
Yes.
And if you can actually differentiate which blood donors are indigenous and which aren't, you might be able to get some data looking at what the prevalence is in blood donors. Other than that, the other way to do it is if there's some suspicions that there might be some disparity occurring, that you do some serosurveys, so pick some communities of indigenous communities and then compare them to any serosurveys that might have been done in non-indigenous people from Mexico and look and see if there is a disparity. And if there is, that information can be used to influence the government to put some resources into doing more testing and linkage to care and treatment of patients who are in the indigenous population.
But I'm going to follow up with a question, and maybe to Alexandra and to Nick, that follows on this question of how do you, so, Nick, you made the point that the research is really critical to be able to advocate. You need the data, but sometimes there are significant challenges and barriers to engaging indigenous communities in sort of standard Western approaches to research. And I guess I'm just wondering if you have any comments on that, about how you sort of have this challenge. If you don't get the data, you can't develop interventions, and if you get the data, you do it, and there may be barriers to that.
Hi, so this is Alexandra King. So first of all, I want to make the point that I don't know a lot about indigenous people in Mexico, so I think it's really important to be making that comment. However, I do know that throughout the world, there are many indigenous people who have had bad experiences with research, Western research, where non-indigenous researchers will come in, they'll do research, and then they disappear. The results are not brought back to community. Community doesn't have control over where these results are shared and so on. And so it does mean that for many of us, we have difficulty in engaging with research. That being said, I think that there are a great many indigenous people who are appreciating the value of research. So it's one of these things that we're saying, yes, we think that it's a good thing, but it has to be done in certain ways. And so how those ways are then would be figured out in a country by country and within region and so on basis. The other thing, though, that I wanted to say is that I was part of an international group of experts on Indigenous health measurement that put together an article that was published in The Lancet in 2016. And unfortunately, there are very few countries that are doing Indigenous health data well. And that means that in many cases, we don't know who the indigenous people are within a country. And then even once we have that level, then we may not know, let's say, a particular disease burden or something by indigenous versus non-indigenous. And this, unfortunately, we're seeing almost throughout the world, is that there are needs for improved indigenous identification, plus then running that through the various data.
No, just quickly, no, absolutely. An engagement of community is critical. I mean, what we would say is that, at this stage of the game, the research may not necessarily be may not be necessary. I mean, we have so many programmatic interventions to give to people that antenatal screening, I mean, it's what we recommend. We have an integrated elimination mother-to-child platform. There's treatment available. So getting programmatic data, using programmatic data when you're providing services to people, which is something that people need, and ensuring that the data that you're getting is disaggregated by Indigenous status is one way to get data without doing research specifically. So they're actually providing a service, collecting data which is useful to national surveillance systems, it's disaggregated by Indigenous status, and you've really killed two birds with one stone. So it's a very good question from Mexico, and I wanted to say that estamos en la misma lucha, entonces, let's do this together.
All right, thank you for the input. I do have another question for you, Dr. Walsh. Thank you for pulling out the article for HCV. You have one publication of HCV in indigenous population, and I would like to add that we do have the risk allele. It's very high in the indigenous population, the risk allele for EL28B. and we don't have any feedback about how much HCV can be circulating in this population. But we do know that we have the risk allele for not clearing spontaneously clearing HCV, nor are we going to respond to the treatment. So
Well,
I think this,
I think that's really an issue for pegylated interferon. I mean, Jordan's the expert here.
Actually, we have a lot of data on that, and I can say that we have a very mixture of IL-28, and there's no difference at all in about 700 patients treated.
With DAAs.
With DAAs at IL-28, there was with interferon, absolutely, but not with DAAs. So if you could have access to DAAs, you don't have to worry about IL-28 at all.
okay, thank you.
Is there another question? Sure.
If we have time. Yeah, if we have time. Hi, Heyman Shah from Toronto. I'm not sure if this mic is on. Oh, there. So this question might sound like a job interview, and I apologize for that, but so many of you have worked on tremendously successful programs, and so many of us are struggling locally to provide good health care to these communities. And I'm just wondering if maybe you can reflect on some of the things that didn't work as you built your programs, and so that maybe we can avoid those missteps.
That's a good question. I'm not sure how to answer that.
So that's a great question. And I would say that any intervention that we try to do without wide political and council, in the case of a tribe, there's the council and the chief and the administration. If you don't get the buy-in from everybody, though, any intervention will fail. I mentioned lab-triggered screening. It was a wonderful intervention, meaning everybody who came into the hospital who had a blood drawn for whatever reason, cholesterol, glucose, if they met the age criteria, and even if they had a signed informed consent in the system allowing us to do Hep C testing, we dropped a Hep C test. And during those 3 months that we implemented it, we were screening 3,000 patients per month instead of the 900 that you saw. And we picked up a lot of positive, almost 1.2 cases per day of, if you can split a Hep C case. But then the council, we did not run that specific intervention through the council, and someone complained and the program went down. We may disagree or agree on the complaint, but so when you don't get political support, that is something that I wouldn't recommend anywhere. The other major barrier that we're having is, as I mentioned, needle and syringe programs. I mean, you really need them because, as someone mentioned today in the lectures, Hep C is just one little leaf on the tree. The tree is populated with other leaves, which are psychiatric illnesses, opiate dependence, intravenous drug use. If you don't address all of those issues, you're also going not to have a complete picture of what you're doing. And I would say those are, I mean, there were a lot of little failures here and there, but they were all tied to not getting everybody's support to start doing whatever the intervention was.
Yeah, I can just add without political support, you really aren't going to get too much done with indigenous populations. You really have to have advocates there that are actually lobbying the government for you and saying we got to get some funding, we got to get some support for what we're doing.
Merv, I don't know if you want to add anything. I mean, that was one of the reasons that we wanted specifically a comment and a discussion about community readiness and sort of the question of, because sometimes the communities may not be ready to think about the problem, and then you don't know what to do first, I guess.
So I think also when we're thinking about leadership, there's also the unrecognized leaders, like, for example, it could be the aunt in the community that like really speaks up and everybody listens to her, like chief and council will listen to her. She's been there for years. I know, for example, in my community, there's an aunt who played that role. So it's identifying the leaders in the community that are going to be listened to, that are going to be heard, and of course, like, and also engaging those that are with the lived experience. I think that when you put a face to people's struggles, I think That says a lot. I know that in indigenous communities, sometimes you see all this, like HIV, for example. They still think it's a gay man's disease, a white gay man's disease, but it's in our communities.
I was going to say, another thing that I find is really important is the sustainability. So, you know, Canada is very good at pilots, and we do a lot of little pilots. And to try and actually get sustainable funding and appropriate funding. So as an example, many of us here would, I think, advocate for the very, very strong need for nursing in hepatitis C care and Hep B care, you know, and yet it's very difficult to get funding for nurses to be going to places. And on the flip side, I think you have to appreciate that from the community's perspective, they have had a whole bunch of pilots. They recognize how difficult it is to get sustainable funding. So I think that you're seeing some hesitation in buying in to begin with, or, you know, they're going to be looking at things from a longer term perspective than what you may realize. So I think that the sustainability of funding is a huge question, certainly here in Canada.
So we have another question from Mexico, I think.
Yes, we do.
Yes, please, go ahead. We can hear you well, so go ahead and ask. Ron? Ron, did you have a question? No question?
1 second.
Okay.
Is that better?
Yes, we can hear you perfectly.
Sorry. This is Ron Sokol from the AMH meeting in Cancun, representing AASLD. And I'd like to congratulate all of you on a wonderful panel discussion. I was wondering, besides the success that you're having in the Native American tribe in Oklahoma, how have other American Native tribes succeeded in eradicating and screening for the hepatitis viruses? And are they having the same success that you're having? And if not, why not?
Okay, that's a great question. So in the last year and a half, I've been working very tightly with Indian Health Services because they are trying to increase screening and treatment on many other tribes. One tribe I can point out to that's having a great success is the Lummi tribe in Washington. Actually, they are better equipped than we are. They have needle and syringe programs. They have good medical assisted treatment programs, and they have very motivated primary care providers treating Hep C. And we are helping them through the ECHO platform. So they did not have any specialists initially, and then they were basically a primary care provider community. And I provide their I still do hepatitis C ECHO with Whitney Essex advice on how to treat patients and overcome barriers like Medicaid requires a specialist consultation, but they will take an ECHO presentation as a specialist, not a face-to-face. The North Portland area also has several tribes that are ramping up and increasing their screening and treatment programs. I think we're at a stage that Indian Health Services is getting more actively involved in expanding screening and treatment access to Native Americans in general. But not every tribe is doing it. Some are facing other barriers and problems. But I think in the next few years, and I'm working with Brian in this subject, I think there is a good momentum that's increasing, and I think it's going to have a good ending in the next few years.
Yeah, I just to add, I think there is a lot more interest now in the Indian Health Service. I think the big problem in the U.S. is the lack of support, lots of verbiage, but lack of funding support from the central U.S. government. And as can be seen by the fact that the Division of Viral Hepatitis receives, I think it is like 2% of the amount of funding that HIV, TB, malaria receive, yet more people are dying of viral hepatitis in the U.S. And the same with, in general, there's an HHS plan, Health and Human Services plan, and there's a lot of verbiage, and they send out lots of emails and lots of rah-rah, but there's no money, there's no real concrete support. And it's really difficult to move the central U.S. government and even the state governments to actually put more effort into viral hepatitis. And I think that's where we really need people who are infected we saw the success of the HIV program because of the lobbying that went on amongst people with HIV, with hepatitis B. That hasn't occurred, and with hepatitis C also, there hasn't been a huge lobbying effort, so maybe NOHEP and other groups will really pick up on this and push governments to say, okay, we got to put money into this and put some effort into this.
Yeah, in Peru we have a big problem too because hepatitis C is perceived like an almost non-existent disease. However, I just showed data that hepatitis C is more prevalent not only in blood banks but also as a cause of mortality in cirrhotic people. So imagine if you have this problem in the States with public funding and attention to the disease, what we have in South America is very dramatic. But despite that, the authorities are still just waking up and realizing that hepatitis C is and is going to be a problem in the near future. Cancer and cirrhosis are big in Peru from hepatitis C.
Just a very brief comment. As our mandate as a Pan-American organization, we'd like to facilitate connections. Obviously, there's a lot of lessons learned in different countries here. We'd like to facilitate connections between countries, Canada, the US, the Brazil, Peru. If we can do that, we'd be very happy to make it happen. The ECHO platform is one way to do it. In terms of exchanging information between countries, there's a real opportunity here at Simposio. So we would like to propose that we might help facilitate some of that dialogue.
I think in the interest of time, I am going to thank all of our speakers for wonderful presentations, and I'd like to also thank the organizations across the Americas that have put this together. I hope this was our first, but we had a concurrent session in Mexico and one here with the Pan American organizations supporting this, and I hope that this is the beginning of fruitful collaboration for future educational and other efforts.
We have another question, comment.
Okay, yes.
Yeah, I'm Fernando Contreras, the president of ALE.
Oh, okay, Fernando, yes, you can. Go ahead.
Well, basically two things. One, to congratulate for the wonderful symposium. I mean, I think we are learning a lot. And second, and actually echoing what Nick says, I mean, this has to be a collaboration between everyone. And I think the medical society has a big responsibility, and I think they can be great tools to contribute to increase the awareness and to be facilitators in each country. And I can talk about ALE, and we are always able and willing and happy to collaborate in any effort that can help us achieve the goal of elimination of hepatitis, viral hepatitis in general. Thank you very much, and again, congratulations.
Thank you. That's, I think, a perfect note to end on, with aiming for future collaborations. And just, if I can also welcome you all to there is the welcome reception for the Global Hepatitis Summit, which will be happening just outside, and you're all welcome to join us. Thanks again.